Welcome to the new Retina Radio Journal Club with the Buckle Society. My name is Kat Talcott. I'm a retina specialist at Coli Institute Cleveland Clinic. I'm so lucky to be joined today by Phoebe Mellen, who's in practice in Pittsburgh, Pennsylvania. Thanks so much, Phoebe, for joining.
Thanks for having me, Kat.
And Kyle Kovacs, who's in academic practice in New York City. Thanks so much, Kyle, for joining us.
Thanks for having me, Kat.
Today, we're going to be discussing the very light and fun paper of Risk of Stroke, Myocardial Infarction, and Death After Retinal Artery Occlusions by Karen Wei at Stanford and her colleagues there. This was published in JAMA Ophthalmology in November of 2023. Phoebe, do you mind summarizing the paper for us?
Happy to summarize. The purpose of this study was to understand the risk of death, stroke, and MI in patients who experience retinal artery occlusion compared with a matched control population. It was a retrospective cohort study conducted using the TriNetX and EHR research network, looking at 111 million patients from across 9 countries. This study looked at 2 cohorts over the course of a 20-year period from 2003 to 2023. They used ICD-10 codes to identify patients with RAO, forming the RAO cohort, and the control population was created using patients who were examined and diagnosed with cataracts. Patients were excluded from the trial if they had a history of stroke or MI within 2 years of diagnosis of RAO or cataract. And then patients were then match controlled within the 2 cohorts, controlling for age, sex, race, and comorbidities, including hypertension, diabetes, hyperlipidemia, and smoking status. Ultimately, the RAO cohort included about 34,000 patients with at least 1 year of follow-up. As for the findings, they found a significantly increased risk of death, stroke, and MI seen in patients at all time points at 2 weeks, 30 days, 1 year, 5 years, and 10 years compared to the matched control group. Notably, there was a relative risk. While the relative risk was highest in the short term, the relative risk of stroke was 21.4 at 2 weeks and 14 at 30 days compared to the control group, which was the most pronounced difference. There was a relatively high risk of comorbid outcomes after RAO events, with the risk of death at 22.7%, stroke at 10.86%, and MI at 6% at 5 years post-RAO. In conclusion, this study shows an increased risk of death, stroke, and MI in patients with RAO at both the short-term and long-term intervals after RAO compared with the matched control population.
That's a great summary, Phoebe. Kyle, any sort of quick responses to the paper? We'll obviously get into it a little bit more after our break.
I really like this paper a lot. That was a really great summary, Phoebe. I think this provides a lot of very important data for practical practice for us. But I also just like a lot of the things that they did analytically in this study. And so one of them was the matching of the cohorts with a lot of the comorbid risk factors that we typically think of for cardiovascular and stroke disease, to really isolate the arterial occlusion as the variable of interest here was, I think, a really important thing, and probably why this study had a kind of a lower number of vascular events in the short term compared to other studies, which I think is kind of a critical thing, that actually it's lower even though the risk is higher. And I think that differentiating the relative and absolute risk, they kind of made a bunch of times. So the relative risk is in these patients is still significantly higher, but still the absolute risk that they're finding is lower. And I think a lot of that has to do with their matching of these cohorts. But I think it's a really really important data set for us for our practice.
I agree. I think this is an elegantly designed paper. This database, I've done some projects with it too, is really well geared towards if you have an ocular condition, sort of associating it with any sort of systemic risk factors or systemic outcomes that happen. And I really liked how they were able to do the propensity matching, as well as to create another cohort to be able to compare it to. So I agree. I think that was great. Phoebe, any sort of other reactions?
I agree with the points that you both made, but I also really appreciate that it's a really large study. It's geographically and racially diverse, and there's a lot of long-term follow-up. I mean, following these patients out to 5 or 10 years really gives us amazing, not only short-term, but pretty long-term data. So I think that this is really an invaluable paper.
Agree. I think one of the benefits of doing these sort of big data studies is you really have the numbers to be able to sort of look long term. You might not have sort of data about individual patients, but sort of getting those large ends and having, 10 years of follow-up is just really important. And I think gives us a lot of information about these conditions and how to interpret it for practice of our patients. All right, so we're going to take a break and we'll get into this paper a little bit more after our break. Thanks so much. Welcome back to the new Retina Radio Journal Club with the Buckle Society. Let's get into a more involved conversation about this paper that Phoebe Mellen really nicely summarized in the first part of this episode. One of the things that sort of I was struck by reading this paper is it really, dials home sort of the risk for these patients who have had a retinal artery occlusion of having a stroke, a heart attack, or death at different time points, after they've had a retinal artery occlusion. And so, the classic teaching has been, if you see a patient who has a new RAO in clinic, to send them to the emergency room for a workup. But sometimes I know that's a little bit more challenging in practice. Phoebe, have you ever experienced difficulty in trying to get a patient to go to the emergency room, and sort of how do you deal with that?
Yeah, so definitely there are, I sometimes will get resistance from patients about going to the emergency room. A patient comes in, they're having some vision problems. Sometimes they think it might be a quick fix, or it might be might need surgery, or, sometimes people come in with different expectations. And then, in the case of an RAO, often, you see the patient, you do your exam, you may get some imaging, and then you say, I treat this as a stroke equivalent, and you need to go to the emergency room. And sometimes I do get pushback from patients. They're like, what are you talking about? I'm not having a stroke. They're not noticing any weakness. They're not noticing any of the other systemic symptoms, the things that you typically think about when you think about a stroke. And I have this paper really drives home the importance of sending them quickly to the emergency room, getting them in the hands of the right people, given how high risk they are for these other comorbidities that are life-threatening. So I really try to drive that home to my patients and say, we need to we obviously want to protect your vision. We want to prevent something from happening to the other eye, but we really also need to protect your life, and we need to send to the emergency room for the full, complete workup.
Yeah, I think that's a really good point. The other thing that I try and be mindful of is, we know that the emergency rooms in general end up being sort of catchment area for lots of patients who can't get care in other avenues or are having trouble accessing care. Kyle, have you sort of experienced that at all with your patients? Maybe, are there other alternatives that we could do besides sending people to the emergency room?
I think that timing is kind of everything. Well, my patients would say, I'm not going to go spend 12 hours sitting in the emergency room. And that's the initial pushback. I'm going to get a huge bill and spend 12 hours. I don't really need this, or that's a waste of time. I'm very, very spoiled at our institution that one of our vascular neurologists started a brainchild of a rescue TIA clinic that they call it, that it's intended initially for patients with TIAs or kind of like strokes well outside the stroke window, but we include amaurosis or RAOs that are kind of outside an acute TPA window if your center's into our acute TPA for CRAOs. And so we kind of get people into a vascular neurologist within 24 hours with the associated workup, which is kind of a win-win for everybody, that they get the very, very expedient stroke evaluation without the emergency room. And I think the vascular neurologists are honestly happier too, that they're not seeing wishy-washy, non-TPA pushing stroke patients in their clinics and getting to do the right workups for them in the appropriate setting. So that's been an amazing game changer for us, because patients are thrilled about that. Somebody's calling them to come see them. They're coordinating the care. They're not wasting time in the emergency room. And it's like that lowered threshold makes everybody, we have 100% follow-up rate, right? Nobody ever doesn't get the appropriate evaluation of that. But obviously that's the bias of an academic center with colleagues who've taken on that initiative that makes that happen, which isn't available everywhere.
It's amazing. Our system actually piloted something similar. Our vascular medicine folks actually came over to our grand rounds a couple of years ago and say they really want to see these patients. They'd like to see them in clinic rather than having to go through the emergency room. So they basically gave us a magic number to call, and they said that they would always be able to add on a patient same day to be able to see it. And from our perspective, it almost seemed too good to be true. And it was too good to be true because I think the people who were often answering those calls had full clinics and often had difficulty finding places to put people. But if you have the resources to be able to have that kind of catchment area, it's much better, obviously, for the providers as well as sort of the patients and their caregivers. The other situation that I feel like comes up a lot more frequently for me when I'm seeing these patients, and this was reflected in a patient who I saw today, is I'm often seeing people who I've diagnosed with a central retinal artery occlusion or branch retinal artery occlusion, but it's clear that they've had decreased vision for a few weeks. They might have seen someone else who sort of diagnosed them and then sort of sent them to me without a workup, or the patient just notes that they've had sort of decreased vision. So it's coming in almost in a subacute situation. And sometimes I feel conflicted about sort of how to handle the workup there for those patients since it's been going on for a little bit. Phoebe, like what's your approach to those patients? And kind of reflecting back to the paper that we read, do the findings in the paper sort of change how you think about what workup should look like for those patients?
I think that's a really challenging situation. If someone has an acute RAO, usually it's straight to the emergency room. But a few weeks later, sit there and think, well, could we do this as an outpatient? Could we talk to their primary care doctor, and how quickly can they get this taken care of? The relative risk was still pretty elevated at 30 days. So I think this does highlight the fact that, even within a month, I mean, they didn't look at 2 months, but I think it's still really important to get them as expedited care as possible. And for me, that would mean the emergency room. In the case of like an asymptomatic Hollenhorst plaque where you don't know how long it's been there, maybe it's been there for months or oftentimes in those instances, I'll call the primary care doctor and speak to them personally on the phone while the patient's in the office, and see if they can get the patient in the next day and get the studies taken care of within a few days. Because I want to make sure that I've clearly communicated the diagnosis and the risk, and the workup that I think needs to be taken care of. And if they feel like they can, manage that in an expedited way, otherwise, then we together kind of make a plan for how the patient's going to get it taken care of in the most expeditious fashion.
Yeah, I think those are really good points. I think I also was struck by in reading this paper that the risk is still really high at a month. So it's not just sort of immediately within the first week that they're at risk, but it probably continues on for a little bit. I think I sort of have the benefit sometimes when I'm seeing these people of being in a large academic center, I can sort of see if they have a cardiologist, like when's the last time they saw their primary care doctor. And so I can get a sense of how easy it might be for them to access care if they need to. If they have a responsible if they have established doctors and then they have someone who's with them who's responsible, I'll sometimes rely on that network to get the outpatient follow-up. But the more challenging situation is when they come in and you have they've never seen, a doctor recently, and that's challenging. What's your approach, Kyle, in those patients in this sort of subacute situation?
I'm also spoiled in other ways, even if it's not something that's so acute it needs an immediate phone call to the vascular neurology. I can also just go into Epic and click vascular neurology referral, needs to be done within must be seen with workup within 1 week or 2 weeks, that there's gradations of every which way. It's like one of the few times I'll celebrate Epic and large infrastructure. But that's the hardest one. These patients who aren't established, they have no background whatsoever. And like, it's kind of the unfortunate thing that sometimes the coordination of care of that is the emergency room, right? It's not just the testing, but actually the coordination of care in the follow-up room for all the different components of it. That's still unfortunately also the answer sometimes.
Definitely. Primary care doctors are hard to come by these days, no matter sort of what system you're in. Just really hard job. I think these were really excellent points. And I just want to sort of just give a shout out to the authors. I think this is a really important paper that I think gives us really helpful information about how to take care of these patients. I also want to thank our audience for listening into the new Retina Radio Journal Club, and please stay tuned for further episodes.